All right, let's get you ready to ace your exams. We're going to tackle the coronary circulation, breaking it all down from the basic anatomy to the tricky pathophysiology. And, most importantly, we'll see how all of this stuff directly impacts what you do every single day. So, let's kick things off with a really fundamental question, one that's at the heart of all cardiac anesthesia. I mean, think about it. The heart is this incredible pump, but what's fueling the pump itself? The answer is its own special and, honestly, pretty complex plumbing system, the coronary circulation. Understanding this is, well, it's non-negotiable. So here's our game plan. We're going to start with the basic blueprint, the anatomy. Then we'll get into how blood flow is controlled. After that, and this is key for us, we'll see how our anesthetic drugs mess with it, what happens when it all goes wrong in disease, and finally, we'll put it all together in some critical situations you are definitely going to face. Okay, first things first, we have to start with the anatomy. You really need to be able to visualize this plumbing in your mind's eye, whether you're staring at a diagram or an actual angiogram in the cath lab. It all starts right here, at the root of the aorta, literally just above the leaflets of the aortic valve. You've got two main players branching off, the right coronary artery, which everyone just calls the RCA, and the left main. Now, the left main is short, and it quickly splits into two other huge arteries, the left anterior descending, the famous LAD, and the circumflex artery. And this is just so cool because it shows you exactly how the theory connects to the real world. On the left, you've got your neat textbook drawing, but look at the right. That's a real left coronary angiogram. You can literally trace the dye from the left main as it splits into the LAD heading down the front of the heart and the circumflex wrapping around the side. It's the same map. Now for a concept that is huge for your exams, coronary dominance. Sounds complicated, but it's actually pretty simple. It just tells us which artery feeds the posterior descending artery, the PDA, which, you guessed it, supplies the back of the heart. For about 70% of people, a big majority, it comes from the right coronary artery, so we call them right dominant. And trust me, this isn't just trivia. Knowing this variation can be clinically massive. Okay, so we've got the map down. Now let's talk about how this whole system is controlled. Because these aren't just stiff pipes, right? It's this incredibly dynamic network that's always trying to balance the oxygen supply with the heart's enormous demand. So the heart has this amazing built-in feature called autoregulation. Seriously, think of it like cruise control for its own blood flow. As long as your patient's mean arterial pressure, their MAP, stays somewhere between, say, 60 and 140, the coronary vessels can cleverly adjust their own resistance to keep the flow perfectly stable. But here's the kicker. If you drop below that range, flow becomes totally dependent on pressure. And that, my friends, is a terrifying place to be. So how does the heart actually pull this off? Well, it's fascinating. And to be honest, we don't have all the answers. But there are three main theories you should know. The first is the metabolic theory. Basically, the harder the heart works and the more oxygen it needs, the more flow it gets. Simple. Then there's the myogenic theory, which says the muscle in the vessel walls just reacts to being stretched by pressure. And finally, the tissue perfusion theory. The truth is, it's probably a mix of all three working together in this really elegant dance. And that brings us to what might be the single most important slide. If you remember one formula from this whole talk, make it this one. Coronary perfusion pressure is diastolic blood pressure minus the left ventricular end diastolic pressure. Now, why diastole? Think about it. When the heart muscle squeezes in systole, it crushes its own blood vessels shut. The only time the inner layer of the heart gets any blood flow is during diastole when it's relaxing. So a low diastolic pressure or a really high LVEP, like you'd see in heart failure, well, that combo will absolutely crush your coronary perfusion. Okay, so now let's talk about us. Where do we, as anesthetists, fit into this picture? Well, every single drug we push can tip this delicate balance of supply and demand, and we absolutely need to know how. Here's a classic exam topic, right? How do our induction agents hit the heart? Well, etomidate is your friend when it comes to stability. It's super gentle on hemodynamics, but you gotta remember it messes with the adrenals. Ketamine is the total opposite. It revs up the heart, jacking up the rate and pressure. That can be a disaster if there's a blockage, but it can literally save a life in something like cardiac tamponade. And good old propofol? We love it because it's predictable, but man, you have to titrate it carefully. And don't you dare forget the gases. Our volatile agents are mild coronary vasodilators, which is good to know. But they also do something else that is just incredible. They can actually protect the heart muscle, kind of prepping it to be more resilient if it takes an ischemic hit later. We call this amazing phenomenon anesthetic preconditioning. Okay, we've talked about how things are supposed to work. But let's be real, a lot of our job is dealing with when things go wrong. So let's dive into what happens when this beautifully designed system starts to break down. So atherosclerosis, this isn't something that happens overnight. It's a long, slow, smoldering disease that actually starts when we're kids. It's this whole process of lipids getting in, the body launching an inflammatory attack, and smooth muscle growing to form a plaque. The really bad day, the heart attack, happens when that plaque finally ruptures and a clot forms right on top of it. This number. Remember this number. Once a blockage in a coronary artery hits more than 75%, it's game over for autoregulation. The vessel just can't dilate anymore to meet extra demand. This is the magic number where blood flow becomes critically limited, and it's when patients start getting that classic angina when they exert themselves. All right, let's get into some real high-stakes stuff. We're going to apply all this knowledge to some of the scariest mechanical complications of a heart attack. This is where knowing your anatomy and physiology truly saves lives. This is such a high-yield point, guys. You have to know this. The posteromedial papillary muscle, one of the little muscles holding the mitral valve in place, usually gets its blood from only one artery. But the other one, the anterolateral muscle, gets a dual supply. So what? Well, it means the posteromedial one is way, way more likely to die and rupture after a heart attack, and that leads to sudden, catastrophic mitral regurgitation. But it doesn't stop there. You've also got to watch out for a VSD, a hole in the heart wall, which can show up about 3 to 5 days after the MI. And let's think about severe aortic stenosis for a second. That big, beefy ventricle has a super high LVEDP, and what does that do? It crushes its own perfusion. Remember our CPP formula? And then you've got the transplanted heart, which is a whole different ballgame. When a heart is transplanted, all the nerves are cut. All of them. Think about it. The phone lines have been completely severed, so the heart can't respond to the brain's signals anymore. So how does it speed up when it needs to? It has to wait for adrenaline and other catecholamines to float by in the bloodstream. This is exactly why a drug like ephedrine, which works indirectly through nerves, does absolutely nothing in these patients. Okay, let's wrap this up and boil it all down to the absolute must-know points for your revision. If you're cramming, this is the slide you want to screenshot. If you walk away with these 6 points, you're in great shape. Know that most people are right dominant. Know that CPP formula in your sleep, DBP minus LVEDP. Know the difference between stable etomidate and stimulating ketamine. Remember the 75% rule. Know why that posteromedial papillary muscle is so fragile. And finally, always respect the weird physiology of the transplanted heart. And just so you know, all this fantastic high-yield info was based on a really great review article by Pathania and Clark. It's from a 2024 issue of BJA Education. If you really want to dig deeper, I can't recommend reading the full thing enough. And look, this brings us to the real punchline. This isn't just theory to pass a test. This is the absolute core of what we do in safe cardiac anesthesia. Every single drug you give, every little dip in blood pressure, it all directly affects your patient's heart. So, the question I'm going to leave you with is this. Knowing all this, how are you going to change your practice tomorrow to better protect that heart?